Welcome to Dental Notes and Mnemonics, and today's video we are going to take a closer look at mixed lytic sclerotic lesions in the jaws. These lesions present both radiolucent and radiopaque. That means the dark and the light areas, they simultaneously appear in a lesion on the radiograph, which can make them challenging to diagnose. Let's explore what these lesions are, how they appear, and what to look for when you are diagnosing them. Apart from the appearance of the lesions on the radiograph, radiolucent lesions have borders which are often well defined and may be corticated, which indicates that radiolucent lesions are benign. While on the other hand, the radiopaque lesions are also having well defined in benign lesions, irregular or ill defined in the aggressive form. Therefore, on one hand, radiolucent lesions may represent often a benign or chronic condition, and radiopaque lesions may indicate a reactive neoplastic or malignant process. So, what should we look when we are going for the diagnosis of mixed lytic sclerotic lesions? However, before that, it is equally important to know the difference between the mixed lytic sclerotic lesions and the lesions having the ground glass appearance on the radiographs. While the borders of a ground glass lesion is usually poorly defined, blending margins with the surrounding bone. On the other hand, mixed lytic lesions are often have well defined borders. If we differentiate both these lesions on the basis of the texture, then ground glass lesions are homogeneous with a smooth or cloudy grainy appearance, while the mixed lytic and sclerotic lesions are heterogeneous with the clear areas of bone destruction and the new bone formation. As we have already discussed that mixed lytic sclerotic lesion is characterized by the combination of lytic areas. These areas appear dark spots indicating bone resorption or loss. And also these lesions appear to have sclerotic areas. That means these are the lighter spots indicating areas of new bone formation. So this mixed appearance of mixed lytic or sclerotic lesion often occurs when both bone resorption and new bone depositions are happening simultaneously, which is quite common in various jaw lesions. Regarding the causes of mixed lytic sclerotic lesion is these lesions can develop in different conditions. This may include benign tumors of cysts, lesions like odontogenic cyst or odontomas may show mixed lytic sclerotic pattern. Inflammatory condition, chronic inflammation can lead to bone resorption and new bone formation, which creates the mixed appearance. Even the neoplastic processes, tumors, especially benign one like cementoblastoma, can cause this mixed pattern due to bone destruction and reparative process. So we'll discuss mixed lytic and sclerotic lesion one by one, and first of all we'll learn about the odontogenic lesions, which appear to have the mixed lytic or sclerotic appearance on the radiograph. First of all, we'll talk about the calcifying epithelial odontogenic tumor. This tumor is also known as pin box tumor. It is a rare tumor. It is generally benign epithelial odontogenic epithelium, and it is characterized by the presence of amyloid material that often calcifies. If we go for the radiographic features of this lesion, typically it can present with a pericorneal radiolency or mixed lytic sclerotic lesion. Characteristic feature of this lesion is a driven snow appearance in some of the lesions, but it is rarely seen in practice. Expansile mixed pattern masses are the most common in CEOT. Small lesions are well defined, while the larger lesions tend to have ill defined borders, potentially indicating a more aggressive phenotype. The location is affected in 75% of the cases is mandible, particularly in the premolar and the molar region, and most cases involves a centrally located unerupted tooth. Clinical symptoms of this lesion includes they grow very slowly and they are rarely painful. More than half of the cases involve the unerupted teeth. Adjacent teeth may be displaced or dislocated, but resorption is uncommon. This helps differentiate calcifying epithelial odontogenic tumor from ameloblastoma. Cortical perforation may also occur in 50% of centrally located lesions. We'll discuss about the non-odontogenic lesions. First of all, we'll talk about the osteosarcoma. Osteosarcoma of the jaw is a rare, aggressive, malignant bone tumor primarily affecting the mandible and maxilla. Osteosarcoma shows the varied radiographic appearance ranging from osteolytic to mixed to osteogenic pattern of bone. If the tumor invades the periosteum, many thin, irregular spicules of new bones may develop outwards and perpendicular to the surface of the lesion, producing the so-called sun ray appearance. Special radiographic feature of osteosarcoma is Codman's triangle, which is a radiographic sign that appears as a triangular area of new bone formation at the edge of bone lesion, where the periosteum has been lifted away from the cortex. This raised periosteum does not fully cover the lesion, creating a triangular shadow between the lifted periosteum and the bone surface. Codman triangles indicates a fast growing lesion, as benign processes typically don't lift the periosteum in this way. Metastatic tumors to the jaw are relatively uncommon and often originate from the primary cancers of breast, lung, kidney, thyroid, or prostate. They may affect either mandible or maxilla, with the mandible being more commonly involved. Tumors can be radiolucent or radiopaque or mixed in lesions. Lytic lesions have poorly defined, irregular, or moth-eaten margins due to aggressive nature. Tumor causes the loss of cortical bone, which may become perforated in advanced cases. Other bone changes are periosteal reaction, widening of the periodontal ligament space in the early stages, tooth mobility, and root resorption. In cases, lesion may involve the bone, which may cause a pathological fracture of the bone. Along with this, the soft tissue involvement and invasion may also be found. The case of a jaw is a bacterial infection of the jawbone that leads to inflammation, bone destruction, and in chronic cases, bone necrosis. It usually results from the bacterial spread, often due to dental infection, trauma, or surgery. The onset of the disease, there may be acute osteomyelitis or chronic osteomyelitis. In acute osteomyelitis, there is rapid onset with the severe symptoms. It often follows a dental infection, extraction, or trauma. But the chronic osteomyelitis develops over weeks or months with a milder symptom but more bone damage. It may evolve from untreated or inadequately treated acute osteomyelitis. In case of acute osteomyelitis, early X-ray may appear normally initially with the changes visible after 10 to 14 days. But in the later X-rays, it shows the periosteal reaction, diffuse osteopenia, and subtle areas of lytic destruction. But in chronic osteomyelitis, X-ray shows the sclerotic, cortical thickening, and sequestra, which is a dead bone segment formation. Involucrum can be also seen in the chronic osteomyelitis, which is a new bone formation around the dead bone, indicating chronicity of the lesion. So now we have reached to osteoradionecrosis. A full video on osteoradionecrosis has been already uploaded on my channel. You may go in the playlist and check the video for elaborate discussion about the osteoradionecrosis there. Bisphosphonate related osteonecrosis of the jaw bones is associated with the use of oral or intravenous bisphosphonates to treat the various bone conditions such as osteoporosis, multiple myeloma, metastasis, and Paget's disease. Bisphosphonates inhibit endothelial proliferation and interrupt intraosseous circulation. Early lesions may appear initially as ill-defined radiolucent area. This is a result of bone resorption and early stages of necrosis. progresses, the bone may start showing a moth-eaten appearance with the irregular bone destruction affecting both the cortical and the trabecular bone. In advanced stages, the cortical bone may become eroded with areas of jaw appearing perforated or punched out due to advancing necrosis. A periosteal reaction, which is thickening or the new bone formation, may be visible. Necrotic bone can separate and form sequestra, which appears as dense isolated pieces in the jaw. And in advanced stages, soft tissue swelling or involvement may be visible. Kindly go through this flow chart. It will help you to make a differential diagnosis of mixed lytic and sclerotic lesion. One of the main challenges with mixed lytic sclerotic lesion is overlap in appearance. Aggressive lesions and benign lesions may look similar, especially on a radiograph. Therefore, a thorough clinical evaluation, including the patient medical history and symptoms, is essential to land into an accurate diagnosis and thus planning a accurate treatment. So this was all about lytic and sclerotic lesions on the radiograph. Hope you like my video. Kindly subscribe to the channel. If you want any video to be made in the particular topic, you may comment in the comment section. Till then, bye bye, take care, have a nice day, and always yearn to learn. Thank you.